Welcome back to the Cincinnati Heart Failure Lecture Series. My name is Mahir Poryahi, and I'm going to be discussing cardiogenic shock. This is the second part of this lecture series, where I'll focus on management of cardiogenic shock. In this section, we'll focus on revascularization, pharmacologic, and mechanical circulatory support devices. Picking up where we left off on the previous lecture, we discussed the definition of cardiogenic shock, the etiology, and risk stratifications. Additionally, we discussed the importance of early recognition and management of cardiogenic shock in order to reduce morbidity and mortality that's associated with this high-risk disease process. To review, we talked about quick, thorough initial evaluation, looking at signs, symptoms, also assessing hypotension and hypoperfusion with other laboratory and other imaging data to help make our decision. The initial management was subdivided into consideration of a transfer to a higher level of care if our center does not normally deal with this high-risk patients, versus cardiac catheterization laboratory for multiple reasons, from a left heart cath coronary angiography to right heart cath for better assessment of the disease process, the level of congestion, and in order to better manage, and or temporary MCS to help stabilize this shock, or at least serve as a bridge for a more durable mechanical circulatory support device versus transplant. And also cardiovascular ICU to better care for these high-risk patients. From there, our focus is going to be about stabilization of this disease process by serial reassessment of shock trajectory. We previously talked about assessing liver function, renal function, and lactates, as those patients with worsening numbers had worsening outcomes. Optimization of therapy to achieve appropriate decongestion, metabolic and hemodynamic targets, personalized intervention, whether that is coronary reintervention versus ablation, whether that's other methods of stabilizing the disease, assessing exit strategies. As you could see on the previous slide, temporary mechanical circulatory support devices play a critical role in our decompensated SCI shock patients. How have we gotten where we gotten today? One of those pivotal trials is the SHOCK trial. It assessed early revascularization in acute myocardial infarction complicated by cardiogenic shock. They utilized a 6-hour to randomization with aggressive intervention versus a more medical management. The primary endpoint of mortality at 30 days showed no difference between the two. However, the longer observations showed better survival long-term in the revascularization arm as opposed to the medical therapy arm. Culprit shock trial furthered our understanding in, again, acute myocardial infarction and cardiogenic shock and PCI strategies. They looked at acute STEMI or NSTEMI complicated by cardiogenic shock with planned early revascularization and versus multi-vessel coronary disease, at least 2 major vessels with greater than 70% stenosis. One arm assessed and revascularized only the culprit lesion, while the other arm revascularized multi-vessel PCI. Primary endpoint was composite of death from any cause or severe renal failure leading to renal replacement therapy within 30 days. And what was seen is that in the group that got the culprit lesion, they had 45.9% of achieving primary endpoint as opposed to 55.4% within the multi-vessel. Now you might ask, how is this subdivided between the two of the primary endpoints? Death from any cause accounted at 43% in the culprit versus 51.6% of multi-vessel. And need for renal replacement, as can be imagined, was more elevated with the multi-vessel being 16% as opposed to 11.6%. No difference in recurrent MIs. This is just to visualize what we just discussed. Having the primary endpoint in the multi-vessel of death or renal replacement therapy as opposed to culprit lesion alone. And here, patients who died from any cause in multi-vessel as opposed to the culprit lesion. Again, you can see the P significance as well. So, what do the guidelines recommend? Intervention of revascularization of culprit lesion has a 1B recommendation. Revascularization of non-infarct related artery has a 3 harm. This, the American College of Cardiology and American Heart Association recommendations are very similar to our European Society of Cardiology recommendations with similar comments. What are the goals of pharmacologic management? It is to mitigate congestion, optimize cardiac output, and enhance an organ perfusion. We're going to look at the first part. How do we mitigate congestion? We utilize diuretics, such as IV loop diuretics, as either a bolus or continuous infusion. There's no difference between the two. There are clinical preferences, however. Utilize thiazide diuretics to further augment diuresis, and or renal replacement therapy. How do we optimize cardiac output? By using inotropes and by utilization of pressors to stabilize hemodynamics. So some of the common things we utilize is the inodilators such as dobutamine and milrinone. Levosimendan is utilized in Europe, however, does not have the IV utilization in the United States. They're looking at it as an oral form to augment some of the HFpEF patients, but not for this cardiogenic shock patients at this point. SOAP2 that came out in 2010 compared dopamine as opposed to norepinephrine in treatment of shock. Cause of shock was cardiogenic. 15.7% received dopamine and 17.6% received norepinephrine. Primary endpoint was rate of death at 28 days, which was 52.5% with dopamine and 45.9% with norepinephrine. No difference seen during the ICU stays. Secondary endpoint was higher rates of arrhythmias, which was seen in the dopamine arm as compared to norepinephrine. So let's discuss intravenous vasodilators. Where to start is nitroprusside, what we commonly utilize. So it's a nitric oxide. It leads to an increase in cyclic GMP, causing a veno and arterial dilation. Half-life of less than 2 minutes. Most common concern is cyanide toxicity, especially in patients with renal dysfunction. Nitroglycerin, similar mechanism, however, has more of a venous or venodilation, and at high doses has arteriodilation. Half-life of about 1 to 4 minutes, and you commonly see tachyphylaxis and large volume in usually patients that are already also congested. Nicardipine, it inhibits influx of calcium into cardiac and smooth muscles. More selectively works on the smooth muscle rather than the cardiac. Has more of an arterial dilation. Has a half-life of about 3 minutes. Limited data in heart failure, and some people are concerned that similar to nifedipine, having its negative inotropic effect on worsening heart failure, whether this could be contraindicated. Having said that, it is utilized in these patient population as a temporary measure, as an IV vasodilator. So what are the differences between our inotropes, dobutamine and milrinone? Dobutamine works as a beta-1 agonist, so it stimulates aniline cyclase to convert ATP to cyclic AMP to increase cardiac output. It has slight peripheral vasodilation. Half-life of about 2 minutes. It can be proarrhythmic, leading to tachycardia as well. And in patients with ischemic disease, it can worsen ischemia and increase mortality with long-term use. Milrinone is a phosphodiesterase. It inhibits cyclic AMP breakdown to increase cardiac output and decrease systemic vascular resistance. Its half-life is much more prolonged. It's renally eliminated, and as such, you can see much higher levels than otherwise anticipated in patients with renal dysfunction. Similar to dobutamine, it's proarrhythmic, and so you should have that awareness. It can be more significant hypotension than the dobutamine utilization. So did we compare milrinone as opposed to dobutamine? Yes, we did. So DURIMI trial, which was published in 2021, looked at adults admitted to cardiovascular ICU with cardiogenic shock, Sky Shock B and higher. Looked at milrinone and dobutamine utilization. Primary outcomes with a composite of in-hospital death, resuscitation from cardiac arrest, heart transplant or MCS or mechanical circulatory support. No difference were truly seen between the two arms. And in the secondary outcome, no difference was seen between the cohorts from an arrhythmogenic standpoint. What about temporary mechanical circulatory devices? You can subdivide them to right-sided and left-sided. I'm going to skip over right-sided support devices for time being. From a left-sided standpoint, you have VA ECMO, so the extracorporeal membrane oxygenation, which provides very high output. It uses a centrifugal flow pump. It requires large sheaths. It increases the afterload on the heart. And so that is usually a device we use in an immediately crashing patient in a very advanced sky shock E patient, or patients that also have oxygenation problems. You have intra-aortic balloon pump, which has a very limited forward flow, about 0.5 to 1 liter per minute. Much smaller sheath size. It helps decrease afterload and increase corneal perfusion. Now, it mentions both the different types of impellas. I'm going to just put them as one. There's a difference on the amount of flow you can get from one to the other. And there's a different sheath utilization. It leads to direct left ventricular unloading as the device sits in the left ventricle and sucks blood from the left ventricle into the aorta. As such, it decreases afterload and increases corneal perfusion. What I will say, commonly Impella CP is utilized either in procedures to stabilize a patient in a high-risk cardiac procedure, whether it's from an ablation versus stenting in coronary disease standpoint, or as a bridge to assess stabilized shock and get them to the appropriate next step. While the Impella 5.5 is for those patients that are in extremis, decompensating significantly, and need a lot of support. What about intra-aortic balloon pump in shock? So patients that were awaiting revascularization with acute myocardial infarction complicated with cardiogenic shock were divided into two groups, intra-aortic balloon pump group versus control group. And what was seen is basically essentially no difference in all endpoints. The graph there to show or demonstrate similar points. So what about microaxial flow pumps? So in Danger Shock trial, adult patients with STEMI and cardiogenic shock were assessed. They were randomized to microaxial flow pump versus standards of care. And what was seen in the study as a result from a primary endpoint standpoint, which is death from any cause at 180 days, is that it was seen or met at 45.8% in the microaxial pump as opposed to 58.5% within the standard arm. What about extracorporeal life support? This was studied in 2023, looking at ECLS implementations plus usual medical therapy as opposed to medical therapy alone. Findings were no difference between two groups. So what do the guidelines recommend? When we look at 2025 American College of Cardiology, American Heart Association, there's a level 2 recommendation for both in patients with STEMI and severe or refractory cardiogenic shock. Insertion of microaxial intravascular flow pump is reasonable to reduce death. And additionally, in patients with mechanical complication of acute coronary syndrome, short-term mechanical support devices are reasonable for hemodynamic stabilization as a bridge to surgery. However, routine use of intra-aortic balloon pump or VA ECMO is not recommended. We come to the end of this lecture. What we discussed was management, covering both pharmacologic as well as mechanical circulatory support devices, and reviewing some of the more pivotal trials. Thank you for listening, and feel free to reach out if you have any questions.